My name's Gabe Carrillo here. My focus has really been on the perioperative surgical care area, and in particular, how can predictive analytics sort of drive the next wave of how we integrate all AI platforms and then understanding those legal boundaries that ensue. So we'll get started. These are my disclosures. We talked about a few of those before. And then I want to kind of give you a little bit of a roadmap of what we're driving toward here. And I start out with what we use for our team, which is called the AIM protocol. I'll go through what that is, why we focus on it, and how we think it plays a role in the perioperative sense. Then we'll go through kind of a case study of what we've done from the research and development side. I'll introduce the IntelliSurge, which is our focused kind of chatbot platform, which is not actually being tested on patients. I want to be clear of that, but it is being done in a sort of research and development lab using kind of de-identified data. And then our legal implications, obviously, is we're at ACLM, and this is a very important thing for us to discuss and go through. And then we'll wrap up with future directions and conclusions. So back to that kind of principle, this is sort of how we start out thinking of what do you do to tackle big issues, in particular that are focused on surgical care. So obviously my interest is in thoracic heart transplants, and that's what I find a lot of gratitude in. But the focus is really about adaptive solutions. What can we do with AI to personalize care? What do we need in terms of the data and intelligence insights to kind of drive that forward to an evidence-based process? And then what's our measurable output? And what are the impacts that we want to generally see in our patients to improve their long-term care? And then I think secondly, I kind of told the team as we were putting a lot of this together, we have an ecosystem of people. What can we take target at? And we asked ourselves, what do we do good at Duke Surgery that many other places might not be able to do? And we mean that with non-hubris or pretentiousness. I mean that just totally do what you're good at. And if you're highly specialized in something, maybe kind of build around that and all the rest of it can kind of flow. So what did we focus on? We focused on hearts because that's what Duke does well. So in Duke Surgery, actually our heart transplant system is the #1 by volume in the United States last year. And we actually have better survival rates. We're about a third of the time to transplant that's there. And just 2 years ago, Dr. Turek, who's a wonderful mentor within the Duke Surgery program, we had done the world's first partial heart transplant. This is baby Owen that you can see down in the bottom right. Baby Owen is doing fantastic. This child, from an adult congenital and then abnormalities of congenital heart transplant, this is game changing, and it has really been a metamorphosis in transplant surgery, and that's happened right here at Duke. So that being said, if we take a step back and look at the larger picture of where we're going with this, and I think as some of my colleagues have alluded to here, CHF is on the rise, and that's the precursor to transplant, but 6.2 million people live with CHF. And each year we do heart transplants that go around 4,000, and each transplant is about 1.6 million. So it's a pretty costly endeavor, but it is game changing for patients. It makes such a big impact on them overall. And right now we're starting to see, are there ways for us to reduce that cost and then preemptively sort of think about what type of reimbursement models and regulatory regime is going to be the best place to do that and the best way to do that. So the learning health system or the smart hospitals, smart homes, all those environments, that is really a riveting area right now, which I think is taking off. And it's all really focused on how do we redefine and improve clinical outcomes for our patients? And how can we use AI within each kind of touchstone of the patient's compendium of care to actually intervene and make a difference? Because from our perspective, and what I've seen at Duke, and loving surgery, there's so much of a difference between what's in the preoperative, what's in intraoperative, and then what happens after they leave our care and go home. And we think that AI has the propensity to really touch every facet of that throughout, as long as it's done ethically, legally, and within the confines that I think make sense, which is why a place like ACLM, I think, will become increasingly important. So, but what can it do? It can risk stratify, it can optimize decision-making, and then it can ultimately improve patterns, process, and for our patients, hopefully, their prognosis. So that's what we're driving toward. And so what did we create out of this? So we really came up with something working with wonderful people as well that are just fantastic engineers and understand this through and through. But IntelliSearch, which is a generative AI platform, goes beyond a chatbot, but does have what we have kind of coined as the phrase a MIRA. So it's a multimodal intelligence response algorithm. And what we think that this does is it sort of coalesces together multiple modalities under one functional entity or one functional tool. And that's and what I asked my engineer colleagues to do was let's keep it simple so you don't want to see what the other diagram looks like, the actual one of all the fusion layers. It looks insane. But this is to be simplistic and to show you exactly what goes into it from a very 10,000-foot view. So first, we have the patient queries. So what are the patient messaging back and forth? And when the patients start to generate messages, I'm having pain, it's increasing distension, I'm nauseated, I'm vomiting, all those kind of things like that that can go into a natural language processing coder and really be sort of a continuous loop within this process. EHR data under clinical notes. That's also NLP and large language models that come in this way. But I will tell you, this is probably the most inaccurate area we have in AI right now. And I think intuitively you can understand that because electronic health records are so like all over the map. And you have different physicians that and surgeons that will like go through and document things a different way. The EHR data, if we could come up with a standardized way to write the notes, that would be huge help, which we'll talk about later. And then image data, right? So this is actually the most standardized. So conversely, over the notes being terrible, image data is actually quite good in terms of its like reproducibility and generalizability. And then telemetry and lab results, because this is kind of patternistic. So beyond the convoluted neural networks, you have LSTM encoders, which are really good at patterns. They have some problems as well too, but that's really what you want to be able to tell, like, is this patient becoming septic? Are they potentially, this is that ICU issue that Dr. Sanders was just alluding to. This is actually where they got hung up on. So it's great that you brought that up. And then all of these things sort of build a feedback loop. So within the model that ultimately says, we got to look at the patients, we look at the plain language, we look at the pictures, and then ultimately the pattern recognition that goes with that. All of those things encompass to make IntelliSearch, I think, functional. So then to kind of get further down to where the sausage is made, you have kind of NLP, which plays a huge role in the transformer-based architecture. We use BERT as well, so, for our model. And then what I just told you about that whole time series health data, this is, I'm trying not to get too much in the sauce here, or in the weeds, I should say, but like, this is really important because the different modality is what determines what data you get. And then the convoluted neural networks, which play a key role and are getting better and better every day. I mean, this is just like the metamorphosis that we're in right now for AI is exciting, scary, and at the same time, like we're blowing through every red tape you could potentially see and trying to get to the other side of it. We just got to do it smartly. So all of those things, they come together to sort of tell us that predictive analytics are critical. So how do we predict outcomes? How do we look at the mortality scores and the index that we know, liberating hospital beds, which makes it potentially attractive to hospitals that are concerned about their, cannibalizing their own business models in some ways by early discharging patients. But the preoperative planning optimization, that's probably the most thing, right patient for the right surgery. And I think what makes a good surgeon is knowing actually when not to do surgery. And at the end of the day, that's really what it comes down to. And then for those patients that do get surgery in the postoperative situation, how can we block infection? How can we block rejection and make it where those patients now that have a very finite resource, which is organs, how are they able to continue on and not have that demise or spiraling of events? So to do that, we said, how do we make our predictive modeling objective? Like, what do we do to drive this? And our primary goal was really to try to integrate AI-powered platforms like IntelliSearch into that compendium of care. Personalize the treatment, which is so, so important because really, you know, the one size fits all, we can do multiple sizes for many. And I think that that's really where we're at with this capability. And then health data integration. Interpret that diverse patient set, the labs, the imaging, the vitals, all those things coalesce into something that can really be integrated well and acted upon. And then what's our alert system? I mean, we know, God knows, when I'm sitting in front of a electronic health record and I get alert, 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 eventually you fatigue to that and you turn off. And we've seen that already with like Sepsis Watch and some of the other things that are out there in terms of those modalities. So it has to be the right alert for the right situation. And you have to find that threshold because it's really key real estate. And then ultimately, how do you evaluate it? It's all about performance, right? At the end of the day, patients need that satisfaction. And if you reduce readmission rates, you've done something. So to be accurate on all of these things, I can't stress this enough. This is a boring slide, but I will tell you this. Data acquisition, pre-processing, and patient-centered care, all of that work, 90% of the work that goes into getting this right, 90% of the work that goes into any AI is all about how do you make the data set clean, normalized, and then encoded in a certain way that it can be used by the AI. This is what takes all the time. So the whole garbage in, garbage out, it's been around, looking where the light is bright, you know, because you're going for the low-hanging fruit. Not a good idea, right? Because those things right there pigeonhole you in, and bad data gives you bad results. And it's important to really do this, to understand this process. And I had to say something about it because it drives me insane. There's a lot of people who just don't understand AI. And when they see that, they don't realize the work threshold that's there, but we're getting better. So I just showed this slide just to be through and through with you guys. This is math, so I won't bore you with that. Hopefully, knowing if you have insomnia, you can read it, but that's how the sausage was made. And then training validation. You got to do partitioning of the data, and you got to do it the right way. So then that way, as you pull data sets apart, you're measuring like against like. You're evaluating those metrics. You're using precision. And then you're comparatively evaluating that with the human in the loop. I can't stress that enough. A human must be in the loop no matter what. And I think we acknowledge that it do quite a bit. And it has to be integrated into each phase. So right now, as I told you, you know, this is all, you know, what we've built in a model by itself off to the side, and we're training it on data that's been completely removed of all identifiers and everything like that within a sort of consortium data sphere. But ideally, it would be you would have IntelliSurge integrated into each step along that compendium. But understanding that, you know, we're at ACLM and that laws are going to be very important along every step of that way, we've got to be conscientious of it, and we've got to put it together to plan to understand what are the legal landmines at play. And they've already been discussed a little bit, I think, too. So we talk about the liability and AI-driven decision-making. These top two right here between liability and informed consent, those are the two that I think I spend the most time because they're immediate. The data privacy and security, these are very important. The regulatory compliance, you know, getting approval of these pre-market, as Dr. Sanders talked about as well too. These are very, very important. But I think in the early innovation stage where we are, it's about really what is that liability right now? What is the culpability of the entity that's using it? How are patients informed about how this AI will help drive the decision? And that's what's important. But all the rest, you know, cybersecurity we've seen with remote patient monitoring, all those elements are critical as well, but we just have to try to get some of these early stage questions answered first. Because who is liable? If you fail to detect or you get a false alarm, those are both equally bad. And who does it rest with? And I don't have a great answer for you, but you know, we've sat down and the powers that be have had some discussions about this. And I think it's actively happening right now to the point where accountability, culpability needs to be almost like a shared responsibility among both the designers in case there's a flaw, the physicians and surgeons who are like in charge of the patient's overall kind of care at that point, and what is their reliance and potential negligence by using those types of tools and not allowing it to become sort of the default, which then you run into a lot of other problems. And then the informed consent, and the option to opt out, which California law is very, very much principled on that opt-out law, which I think will become the standard. So then beyond kind of the legal element is just the ethical consideration overall, right? What are the ethics, evidence, and equity of this process as it unfolds? Historical data that we have within the hospital context is really skewed in one direction, and it doesn't have as much generalizability as we need. So you have to have diverse data sets. You have to have equitability across the board. And you have to understand as well that this is a really, in heart transplants in particular, which are my passion, that area is very difficult because organs are finite. A heart is very valuable. And you have to make sure that you do choose the right situation optimally, that the patient will do well with it because it's such a finite resource, and so it's difficult. It requires ethicists to come in. It requires attorneys to understand that, and it requires doctors to really be in the room about that shared decision-making and multidisciplinary approach. So this is what I'm most interested in, is that post-operative monitoring. So when patients are able to early discharge from the hospital, and thank God, because COVID right now has really transformed our wearable market, our remote patient monitoring. I remember when I was a cardiac cath lab nurse years ago, and we would do it where, I remember Boston Scientific and St. Jude really rolling out that first kind of entity of home monitoring, back in like the early 2000s. And now where we are for RPM is just ridiculous. It is night and day. In particular, COVID streamlined a lot of that, but the wearables are new and they are amazing. And the ability to reach underserved populations, the rural parts of states that are very far away from us. At Duke, as a major academic medical center, a lot of our patients are super far. And they have to come here, they have to stay here, they have to be next to the hospital, especially if we just transplanted them. So it's a really big inconvenience. But if they had broadband expansion, bipartisan infrastructure bill is pushing that, then that underserved community population can maybe be reached better. And we can tailor those interventions to them. It's really amazing time. And I just think, I'll skip over this, but the big thing is, I'll say at the bottom, convenience beats out competition. And if you can make it more convenient for them, you will have a competitive advantage, and digital health allows that. So we can't go back. We're going forward. And I think that's the only way to go. We just got to figure out the rules of the road. And I think that forward progression is really hospital at home. This is not a new model per se, but it is much more in line with the metamorphosis that we are seeing take place. And that hospital at home is about early discharge, understanding that patients can be in the home-like setting instead of in the hospital for a protracted period of time, in particular for like heart failure patients, but transplant patients as well, because that modality is becoming better and better and better every day. So the next steps on this, I think, and takeaway overall, is that IntelliSurge is, I think, an ideal kind of little bit of a rough shot litmus test for beginning these processes. And I believe that each hospital system should kind of look at how they can partner with startup companies, major academic medical centers and startups together with the right incentives and the right guardrails to prevent, obviously, bad incentives. They can then set the standard. And as a result of that, we can sort of balance that AI integration into these areas. And we can have all that multidisciplinary approach really do something big for our patients, because AI is moving at such a fast rate and it's almost unbearable to keep up with. But what I know is medicine, which usually lags, is finally beginning to wake up and to see we got to do something better, because whoever runs the kind of rough shot, over the top arching theme of AI will really control the stage. And I think from a national security standpoint, it's very important. So anyway, looking ahead, stay tuned. We'll talk about this in February as well at the big conference. And we'll talk more at that point in kind of series 2 of hospital, home, and critical care transplant patients. And we'll deep dive there. So that's basically it. Thanks so much. Appreciate being here.